Welcome back as we continue with our hematology series. Previously, we've covered CLL with Dr. Nitin Jain and newly diagnosed multiple myeloma with Dr. Caitlin Costello. Though our treatment options for multiple myeloma have improved and patients are living longer, unfortunately, most do relapse or have progressive disease after their initial treatment.
Today, with my co-host and brother, Rahul Gosain, we get a chance to focus on relapsed and refractory myeloma, where we have seen plethora of new approvals, including bispecific antibodies and CAR-T. To take us through our available options today, we are joined by Dr. Samir Al-Hadidi, a myeloma specialist from University of Arkansas. Samir, thank you so much for joining us.
Thank you for having me.
Samir, we have a lot to cover. To set the stage, if a patient has received a quad therapy upfront and post-transplant, they're currently on LEN maintenance. How do you monitor these patients in your clinic, and what time do you start discussing escalating treatments with them?
I think that's a great question, and you set up the stage with the quad-based therapy specifically because they're used nowadays more often. And in those patients who are on Revlimid maintenance, many of them they go for a really long time before they run in any trouble. So those patients usually go for transplant and they're taking maintenance Revlimid. And the usual way I look into those patients are frequent blood testing. So it's anything between 6 to 8 weeks. I usually check their myeloma markers, including both electrophoresis and the free light chains. And when it comes to more advanced sort of testing, there is lots of variability there. And I think we should govern most of those testing according to the patient, the disease characteristics, for example, being standard risk or high risk. Some of those patients have longer remission rate, time compared to others. So I usually also try to get occasionally bone marrow biopsies and advanced imaging, but this is not for everybody. Mostly patients who are actually being monitored, and also they like to check those things. So many patients actually are interested to know what's happening with their bone marrow biopsy, for example, and do they request to do those testing. But I think for the general oncology point of view, most of those patients need to be checked with their frequent blood testing mainly. And if those blood testing are showing some, worsening or something that is concerning, then other testing they usually can be obtained.
Samira, thank you for laying that foundation. When you are getting repeat bone marrow biopsy, is there any role of repeating cytogenetics? Is there any concern that that can evolve?
I think that's a great question. I think outside of research, I would likely not, be interested to repeat cytogenetics in general. We're lucky here in our institution that we do that as a standard for all patients who do bone marrows. But we realize that many patients who do their bone marrows, with their, oncologist, they may not be able to repeat those cytogenetics. So I think as a standard, there is no real need to repeat the cytogenetics unless the initial one was not obtained for a reason or another. I think that would be a good idea to get it.
Perfect. So now you have your repeat bone marrow biopsy. Unfortunately, you see M spike is trending up, more plasma cells in this bone marrow biopsy. And as we said, they're on LEN, so technically now LEN refractory. We have quite a few options. Are you going to reintroduce anti-CD38 with proteasome inhibitors? Are you going to try a different combination? What are you thinking?
Well, I think that's a really important question and extremely common in practice. So those patients who actually they have evidence of relapse disease, I think first of all we need to look at a few characteristics for the disease and the patient. So now patients tend to get older with time, and they may be in the same excellent shape, for example, they had before. Maybe they got some few more comorbidities they didn't have from before. Some of the treatments we use, like for example, there are VRD, may result in some peripheral neuropathy, which can be a consideration to have, or other side effects, for example, that we need to keep in mind when making a decision on what will be the next sort of a treatment regimen. I usually think of it in two different ways. Most of those patients will get an anti-CD38 based regimen because most of the relapse refractory trials over the last few years did include an anti-CD38 at time of relapse. And since most of patients who get DARA-RVD are not maintained on daratumumab maintenance, then those patients will be exposed to an anti-CD38, but they're not refractory to it. So I think it's extremely reasonable to introduce anti-CD38 based kind of combination. And as we all know, triplet-based regimens in relapse refractory setting was found to be better than doublet-based regimen on almost all the trials that were done in relapse refractory. And so I usually try to give those patients another companion drug that is more appropriate to their disease characteristic and also their other medical problems. So that could be anything between another proteasome inhibitor or even the same proteasome inhibitor, Velcade, assuming that the patients did not have refractoriness to Velcade or side effects to it, or a new immunomodulator drug. So the major two philosophies there is either to do anti-CD38 with carfilzomib-based regimen or anti-CD38 with a pomalidomide-based regimen. And those are a little bit sort of different because carfilzomib tend to be a medication that we may be a little bit worried about using it with patients with cardiac comorbidities who are older. So for those patients, using pomalidomide may be more appropriate. But if we look at efficacy data, there may be some better outcomes with carfilzomib-based regimens. So if we're looking purely at efficacy data, using a carfilzomib-based anti-CD38 may be more reasonable from efficacy point of view.
Samir, thank you so much. Well, we have also seen CAR T move into earlier lines. To emphasize here the importance of us in community setting, it is so important for us to collaborate with tertiary and quaternary centers so that we can offer these important therapies to our patients. So, what data do we have for CAR T and bispecifics when you are using these options?
Yeah, I think you're bringing up an excellent point with the collaboration between, a community oncologist and, in general, academic oncologists who do such CAR T therapies, for example. You know, those patients who get relapse disease with myeloma, some of them, we know they don't do as well. And those patients are usually the patients who get a short control after transplant, for example, or they're on triplet or quadruplet based therapy and they're progressing while they're on that treatment. And those patients, actually, CAR T cell therapy play a very important role in this subset of patients. And it's very important to try to identify those patients early and refer them early because, as you know, CAR T requires planning, planning that takes weeks to months to achieve the actual goal of giving CAR T cell therapy. So nowadays we're actually lucky to get one of the CAR T therapies approved in the US to be used after one line of therapy, and that is cell to cell. And that was a very recent approval in 2024, where we can use such product after one line of treatment. And I think there are a subset of patients in really immediate need to get such therapies if they have, for example, progressed on a quad-based induction and a transplant early on. And we also have another CAR T cell therapy that's now approved after two lines of therapy. So both of those CAR Ts now are available for early relapses. Back in the day, we used to have those CAR Ts approved after four or more lines of therapy, which is the same indication nowadays for the three bispecifics we have, teclistamab, erlonetamab, and talquetamab. Those three bispecifics are approved after four lines of therapy. So I think the collaboration is extremely important and also depends on when the relapse is happening. So for example, if somebody has an early relapse, CAR T tends to be something that is available nowadays to discuss with patients compared to later relapses where both of those options are available.
Rohit, Samir, I agree that collaboration with tertiary or quaternary center is important, but at the end of the day, these patients receive these newer therapies at these bigger centers, be it CAR T or bispecific, but then they end up closer to home for supportive care. And I think it's important for us in the community to be mindful and cognizant of the side effects and the supportive management that these new therapies need. Samir, can you dive into a few side effects in supportive care when it comes to CAR T or bispecifics here?
That's great question. For CAR T cell therapy, the way I think about it, there are short-term and long-term side effects that patients may encounter. Short-term side effects usually happen around the time of getting the CAR T cell therapy. And Per the approval of those products, the patient should be staying within an approximate sort of location to the actual CAR T center. So some of those side effects may be dealt with by the actual CAR T treating physician. That includes increased risk of infections, for example, cytopenias, and so on. But after patients go back home, they want to follow up with their local oncologist, and at that time, it's extremely important to watch for sort of long-term side effects that could have happened with CAR T cell therapy, and that includes cytopenias. Some of those are prolonged. So if you look at the clinical trials, for example, there are some patients who have some sort of cytopenia, including leukopenia, anemia, and thrombocytopenia with grades of 3 or more that persist for 3 or more months. And I think that's extremely important to follow those patients more often in the clinic and provide them with supportive care, including possible transfusions or possible growth factors to allow their count recovery. And I think that's extremely important in case of CAR T cell therapy. The other side effects we need to watch for are increased risk of infections. And this usually starts when the patient get the CAR T cell, but also persist to the time they go back to the community. And that includes some of the infections that we're all aware of. But I think we need also to be aware that some of the infections that could have happened for patients who get CAR T cell therapy may be the unusual infections that otherwise do not cause much of a trouble to patients, but for those subset of patients may result in some extra problems. And the last thing I think that we're really learning a lot about CAR T now with using it early on, and there are some rare side effects that are being reported nowadays. For example, like increased risk of myelodysplastic syndrome or acute myeloid leukemias that we need to continue to watch and suspect for those patients who get those CAR T cell therapy, and also rare cases of movement-like disorder or Parkinsonism sort of features that also were reported. So those are extremely important to kind of follow and look, especially in CAR T cell therapy. When it comes to bispecific, I think the role of community oncologists is even more important because those patients nowadays we're seeing them starting the treatments with their local doctors, and more importantly, they do most of the treatments with their local oncologists. And I think there is lots of things that now are done much better with bispecifics compared to the time we started it. For example, we did learn that patients who get bispecific antibodies, because of how effective is those drugs, they sort of shut down the normal plasma cell function, and the patients have increased risk of infections. And those infections can be prevented by doing some, first of all, early realization about the infection, and second of all, sometimes providing patients with IVIG, for example, to prevent infections. And those are important measures that can be done by the local oncologist to prevent infections and treat it early should we run into this problem. So I think that's very important to watch for infections because this side effect is quite common and risky to watch for. The other thing is also we're learning side effects of those drugs that we did not know about when we started using it. For example, if we talk about the drug called talquetamab, it's it's a drug that commonly result in some skin side effect, taste side effect, and those we need to be aware of those side effects, number one. And number two, there are some maneuvers of spacing some of those dosing that can help with some of those side effects. So I think, watching for the side effects, specifically the risk of infection, low blood counts are extremely important when it comes to bispecifics.
Thanks so much, Samir, to cover that so comprehensively. Us as community oncologists, we need to get more aware about this. Again, as you mentioned, that we will be the ones taking care of them after CAR T or while administering the bispecific antibodies. Now, just another question, rather, for we have the treatment option of selinexor, but I continue to wonder, in fact, who's the right patient? Have you utilized this option, or who do you think is the right patient for this particular drug?
I think that's a great question. In myeloma, we were lucky nowadays that we really have too many options. And that
Indeed.
makes the decision between those options a little bit, easier. Because, for example, nowadays, if I want to give an efficacy decision, those bispecifics, for example, they result in at least double the amount of response compared to selinexor. So I think, selinexor is one of those drugs that got its days where we used it more often nowadays. Nowadays, we likely will be losing it get less often, the reason why we have better options. But bispecifics may not be the for everybody. There are some patients who may have a preference not to get it, for example, or a reason to prevent them from getting it. I think that's using selinexor is one of the approved agents to be considered for patients. But I do think nowadays with those bispecifics and CAR T cell therapy, especially with the fact knowing that patients nowadays they don't continue to have the privilege of getting more and more lines of therapy, proceeding with a more appropriate treatment option will be really important. And so I usually tend to use more bispecifics and CAR T cell therapy for such patients, or some of the other well-established drugs. But there are many local oncologists that may entertain the option of selinexor, and if that is the case, I usually suggest using really lower doses than what you used to use before, so patients can tolerate that better, and be aware of the side effects that could have happened with it and try to prevent it with some appropriate pre-medications. So those are the two sort of warning things I usually give to patients who are receiving this drug, especially if they're tolerating it well and they're getting some sort of response to it.
Yeah, Samir, thank you. You brought up bispecifics, and the efficacy is so important here. There's such active agents. Out of the three, how are you deciding which one are you using and in what line?
Well, I think you're bringing a very important question. So it all tends, to be honest with you, onto how those agents were developed. BCMA-based therapies were developed prior to GBRC5D. So both teclistamab, erlotinib, and just as by default, people were using those in practice before using GBRC5D. But technically, there is no reason why you can start with one and follow it with the other. I think the good thing about those two classes, they both work on different sort of receptor. So, for example, if you have a patient in the clinic and you want to use one of the bispecifics, I think either going with BCMA bispecific or GBRC5D is appropriate. Most of us go with BCMA-based therapy first because they tend to be tolerable, number one. Second of all, you can try to avoid some of the side effects that could have happened with GBRC5D, while you can subsequently use the GBRC5D after BCMA failure. So I think that's very important because we know, for example, if somebody gets teclistamab and they progress on it, that you can give them talquetamab. And I think this is also appropriate for the other way around. So if you get some patients who got talquetamab and then he gets or she gets teclistamab, they may respond as well. So for most patients, I would preferably use BCMA-based bispecifics, unless the patient have likely, lots of infections before. Really, I may favor going to GPRC5D bispecifics for this specific patient. But I think you don't go wrong by choosing any of those because those efficacy are really good. And with anything between 2/3 of patients having some sort of response, which is really good.
Thank you.
Thanks for covering those important clinical pearls, Samir. Any last thoughts for us in the community when it comes to managing patients with relapse or refractory multiple myeloma?
I think there are things that we tend to maybe forget that we need always to remind ourselves about it. For example, there are drugs that we used to use in the olden days, sort of, they work really well in patients with relapsed refractory disease. Some of that include the alkylators, including cyclophosphamide, for example, and thus using that can actually result and control of myeloma for a good amount of time. And some of the progression-free survivors reported in randomized trial using cyclophosphamide-based regimen was really, really good. So I think that is something we need to keep in mind, that some of those older drugs are things that we can do. And the other thing I also will point to, that there are subset patients with a specific translocation, which is translocation 1114. Some of those patients may benefit from the use of venetoclax. So I think that is for this subset of patients is a consideration to use. And so we need just to keep an eye on the initial FISH. And for those sort of patients, consider using some regimen with the use of venetoclax.
Samir, thank you so much for taking the time to cover the current treatment landscape for relapsed and refractory multiple myeloma, which is literally changing by the day. For our listeners, let us go over a quick recap.
Multiple myeloma is a complex disease with varying degree of outcomes for different patients. While some patients may achieve remission or stable disease for a long period, most do experience relapse or disease progression. In this discussion with Dr. Samir Al-Hadidi from the University of Arkansas, we focused on relapse and refractory multiple myeloma.
Though we have multiple treatment options here for multiple myeloma, getting comfortable and managing the side effects with each treatment modality is extremely important. In the community, we must collaborate with tertiary and quaternary hospital systems to ensure patients can access CAR T or bispecifics as they continue to make their way into earlier lines. Thank you for joining us. Make sure to check out our newly diagnosed multiple myeloma discussion with Dr. Caitlin Castello and the CLL discussion with Dr. Nitin Jain. We are the Oncology Brothers.